Thank you, everybody. So this is a talk that I gave at two of the breakout sessions, and so if you were there, this will be the same one. If not, this will be new to you. So you heard a lot about imaging during the course of the last 2 days. You heard a lot about imaging earlier during the pro-con debate with Drs. Hogarth and Shah. So you hear a little bit about the science behind the imaging right now. So the current challenges that we have in diagnostic bronchoscopy, you already heard this many times over the course of the weekend, is CT body divergence, right? And that's where the nodule is on the planning CT is a different location than where the nodule is during the procedure. And we saw this very frequently, although we couldn't really measure it until we started doing bronchoscopy in the cone beam lab, right? So, and when you're doing cone beam CT, you could actually see the location. You could compare it to where the location is supposed to be, and you see this divergence. And that's important because you want to aim at the right target. You want to get your tool in the right target. Dr. Pritchett did a very elegant study several years ago, looking at where the nodule was supposed to be, which is the red, and then comparing it to where the nodule actually was using cone beam CT, which is the blue, and then he measured the distance between the two. And he found that almost a third of the nodules didn't even overlap. 2/3 of them only had minimal overlap. So it just illustrates how much CT body divergence actually happens. On average, it's about, say, 10 to 15 millimeters in the upper lobes, could be 20 to 25 millimeters in the lower lobes, which is pretty significant when you think about it. It doesn't matter if it's electromagnetic navigation or shape sensing, right? There's two different robots on the market right now. One uses electromagnetic guidance, two use electromagnetic guidance, one uses shape sensing. This is a study that shows shape sensing robots, the ION, has just as much CT body divergence as electromagnetic navigation. So what's the solution? Well, the solution we should learn from our interventional radiology friends. They put a needle in a nodule, and then they use a CT scan to confirm that it's there. So why couldn't we apply the same principles to bronchoscopy? Just using imaging, let's see if we could prove that our needle is in the nodule before doing the biopsy, or our tool's in the nodule before doing the biopsy. So let's just talk a little bit about what cone beam CT is and digital tomography is. This is your standard CT. This is the CT scan that you use on your patients that you do normal when you want to send for a diagnostic CT, this is the CT scanner that they use. It uses a fan beam, which is a very thin beam of radiation. It comes out like a fan, and it spins around the patient in a spiral fashion. We used to call it spiral CT in the US, but this is just your standard CT. This is not a cone beam CT. Cone beam CT is a completely different principle than this. A cone beam CT uses a cone beam emitter. Okay, it comes out like a cone instead of a thin slice. And as the cone beam emitter emits radiation, it spins around the patient with the emitter and the gantry in the same plane. If it's a wide angle spin, say over 180 degrees, then that's called cone beam CT. If it's a narrow angle rotation, say around 60 to 100 degrees, it's called digital tomosynthesis. So cone beam CT is really digital tomosynthesis. It's just a wide angle digital tomosynthesis. Digital tomosynthesis was first used in breast imaging and breast biopsies. It was more convenient than doing this under cone beam CT. So really all it is a series of images. The images get reconstructed into 3 dimensions, and then you have your image on the right. So why can't we just do this for bronchoscopy? And this is the basis of digital tomography. This is the basis of advanced imaging that we all talked about over the past couple of days here. The main difference between cone beam CT and digital tomography is the depth of focus. Because you have so much more data, because it's a wider angle spin, you have a much deeper depth of focus in cone beam CT than you would in digital tomography. In digital tomography, the only thing that's clear is the center of that spin, which we call the isocenter. So you don't get depth, you only get shallow. So it becomes very, very important to make sure that when you do these spins, you're at isocenter. Here's a perfect example. There's the nodule. As you spin this from 30 to 30, if the nodule is in the isocenter, it will show up on the same exact area on each of those films. So when they're put together by the software, everything looks stacked on top of each other. You get a nice clear image. These are the factors that affect image quality in cone beam CT. The detector obviously is important, right? So the more pixels you have, the more clear the image is going to be. The algorithm that puts all these images together is also important, and obviously the sweep angle, which we already talked about. Isocentering the nodule is super important. This is how lung vision does it. You actually see where the main carina is. You mark the main carina. You compare it to the main carina on the CT scan, and then the software will tell you where to move your C-arm so you get isocenter of the lesion. Galaxy is another technology you saw earlier today. Kyle presented that also uses digital tomography. They use the tip of the scope after a navigation to approximate where isocenter is. These are the images that you get. Look at they're beautiful images. These are images done with just a standard C-arm fluoroscope, not a cone beam CT, a fluoroscope. And these are pretty good high quality images. In addition to the high quality images you just get from the digital tomography, there could be post image processing that could be done to make these nodules look more clear. You could see the same nodule on the left. It's image enhanced on the right to become more dense, solid, and clear for you to see. Here's just representative images over a series of 3 different C-arms. One side is the actual CAT scan image. The other side of this is the reconstructed image that we get off the DT, and you can see the pre-op CT on the left, the ScioSpin reconstruction on the right. This is the GE 9900. This is the C-arm that I use, a very old C-arm, but a very standard C-arm. You can see the image quality that you get is very, very, very good. How about subcentimeter nodules and subsolid nodules? And again, you could see that on the left you could see the subsolid nodule, the subcentimeter nodule on the left, beautiful reconstructions we get, and even subsolid nodules, that GGO, excellent reconstructions that we get after just a 60-degree spin. So what can we do with this image integration? Well, the first thing you could do is target location updating, right? So you're targeting the right nodule, the right space where the nodule is. You could take that information, use more algorithm, and do augmented fluoroscopy, which you saw several times already this weekend as well. And then if you really have a supercomputer working with you, you could have targeting functions. And targeting functions work best with robotic scopes that have sensing catheters at the end of them. So it's almost like you're playing a video game. We've seen these videos already this weekend. This is using augmented fluoroscopy to access this. Again, the yellow ball is exactly where this lesion is. And you could use it both to access and then also to biopsy. And I think we've seen these again already this weekend. Imaging angles are very important. Okay, we've seen several examples of this over the weekend. Remember, just because you're seeing something with augmented fluoro in a coronal view or the AP view, that only tells you where you are in that one view. You could still be in front or behind of the nodule, you'll never know. So when you use the technologies like lung vision, you have to become adept in looking at oblique views. And for instance, with lung vision, that yellow ball will move with you wherever you go within that scanning range, okay? So it's a very simple concept. If this is the blue ball and the person there is the nodule, the arrow is your needle, and when you do an AP view, it'll look like the needle is in the nodule. However, when you do a spin, if your needle's not centered, if it's anterior to the nodule, it'll move away. So we have these little conventions that we do. So for instance, if the nodule is in the right upper lobe, you spin to the right, and then the needle moves to the right with it. That means you're anterior to the nodule. You know, we used to have this taped to our C-arm, but it's all embedded in our brain now from doing so many. But you could very easily, using augmented fluoroscopy, understand where your orientation is with your needle in regards to your nodule. And here's a perfect example of that. This is the AP view. You could see where the tip of the catheter is in relation to the nodule. When you spin it to the right, it goes to the left, which means you're posterior to the lesion. The other cool thing that we could do here is targeting, and I'm not going to spend too much time on this, but again, a really nice tool to have, because you could literally target right to the center of your nodule. I find that augmented fluoro is really important. You look at this needle, the needle is going towards, but then diverts away. If you had augmented fluoro, I think Kyle showed this before, you could show your tool going directly into the augmented fluoro image. It goes exactly where you want it to go. The tool and lesion confirmation we've seen several times. You know, the cone beam guys use this a lot, but this is imaging that's done off of a regular mobile C-arm, and you could get really great imaging. This is what I consider, you know, exactly what I intended to do during the procedure. Again, small nodule, great images, small nodule, great images, tool and lesion images is really, you know, what I consider a successful navigation. Lung vision has many other different ways you could look at these nodules and look at the approaches to the nodules. You could, you know, this nice little 3D spin. Again, this is driven off of a 2D fluoroscopy. This is imaging that you would probably get off a cone beam CT. Kyle showed you these reconstructions before. These aren't ready to be here yet. They'll be here in about 6 months. But these are amazing reconstructions that you're getting just from 2D fluoroscopy that are reconstructed using very advanced algorithms, machine learning over tens of thousands of training sets. So how accurate is digital tomography compared to cone beam CT? Well, actually, it's very accurate, within 1 millimeter of each other. So even though you get a slightly lesser quality of image, the information you need to get from it is exactly what you want. Is there data to suggest this? We've seen this all throughout the weekend. Yeah, there is. And the data shows that when you add imaging to your procedure, you get a better diagnostic yield. So to summarize, although cone beam CT, and you've been seeing a lot of that over the weekend, gives you maybe superior images, digital tomography could still produce imaging with sufficient resolution to get you what you need, which is basically proper isocentering and tool and lesion type of biopsies. You want target location updating. You want to be able to get your tools into the lesion. It's best, I think, when utilized with augmented fluoro. I think we've proven that with our service in Cleveland, that as long as you learn how to use your augmented fluoro with oblique images, you become a really powerful bronchoscopist. DT could be used without targeting. Targeting will come once you get your robots here, and you will get your robots here eventually. I think I'll end it at that. Thank you, everybody, for your patience. Thanks for sticking around as long as